All right. Well, good evening, everyone. I want to thank, on behalf of the ACHQC, want to thank everyone for joining tonight's episode of QC Core Insights. My name is Jake Greenberg. I'm a professor of surgery at the Medical College of Georgia at Augusta University. We have really a fantastic program, I think, set up for everyone tonight. We might be joined by another moderator, potentially Nicole White or Rebecca Peterson from the University of Washington. We're just waiting for one of them to potentially get out of the OR as they are a little bit stuck. But it's my pleasure to introduce our speakers for tonight. We're going to have 3 different talks, and then we'll have some time for Q&A. We're going to try and keep this right at a hard stop of an hour, so at 9 p.m. Our first speaker is Dr. William Hope. Dr. Hope is in New Hanover Regional Medical Center, a past president of the AHS. He's going to be speaking about the case for prophylactic mesh to prevent incisional hernia, which was a big part of his work as the president of that society. This will be followed by Jeremy Warren from Prisma Health in Greenville, South Carolina. Incredibly talented MIS and robotic surgeon with a strong focus on hernia repair. His neck is a little stiff as he recently fractured it, but he's looking okay without his seat collar on. He'll be talking about hernia repair with concurrent ostomy reversal. And our last speaker is Dr. David Krpata from the Cleveland Clinic in Cleveland, Ohio. Another well-known MIS and hernia surgeon, partner of Dr. Michael Rosen's, and he'll be speaking about his prophylactic mesh, truly benign. So we'll go through all 3 talks. I'll be monitoring questions both in the chat and if you want to raise your hands, but we'll hold the questions for a Q&A session at the end. So we'll go through all 3 talks and then use all the rest of the time to let our speakers all answer questions. So without any further ado, I'll turn it over to Dr. Hope and the case for prophylactic mesh to prevent incisional hernia.
All right. Thanks, Jake. Thanks to the QC for letting me discuss this. Let me see. I think everybody can see me. So I was tasked in giving the case for prophylactic mesh to prevent incisional hernia, and I do have a disclosure slide. I work with several mesh companies and a few startup companies that deal with mesh and some abdominal wall closure devices, none of which really, although we'll speak about mesh, we'll speak of generalities. I've been speaking on this for a few years, so I really kind of updated a bunch of slides and really tried to think of a way, because I think while we've made some cases for prophylactic mesh, we clearly haven't done a good job at this, because the sort of use of this, at least in the United States, except for small pockets, is pretty sparse. And I think clearly we'll talk about some of the reasons why. But I really wanted to kind of go through sort of an argument, almost like a legal argument, of why this makes sense and why we should at least be considering this as an option. And I hope to sort of sway you that this is, at least on most of these topics, that there's a logical conclusion that prophylactic mesh may be reasonable. And so I'm going to try to answer a few questions here, or ask a few questions, and really, hopefully at the end we can all agree on some of these. And I'm going to start with incisional hernia is a problem. We'll go over some data about that. I'm going to discuss how good we are at fixing hernias, and that can be debatable, but I'll try to give you some reasonable data about that. Can we predict who develops an incisional hernia? There's some newer data coming out about that, and I think clearly that's going to be important when we talk about prophylactic mesh. And then, if all these things are true, are there ways that we can intervene to reduce the chance of an incisional hernia? What are the evidence and what are the downsides? And I won't go over too much of the downsides, because I think Dave's going to talk about that. So really quickly, first to start, I don't think this is going to be hard to convince people that incisional hernia is a problem, but I think we need to look at it, because all of us sort of make our living on fixing hernias. But there's a lot of data. Ben, one of our fearless leaders of the QC, did some work. This is a really often quoted study, just because at the time there wasn't a lot of this out there, but really just looking at how big a problem incisional hernias were. There's a lot of cost data in here, and you'll see some of these studies just by merely impacting some of these trends. In this particular case, 1% of a reduction in recurrence, we could save $32 million, and you'll see some of these further data. But clearly, this was thought of as an issue. A lot of people say, well, what about laparoscopic surgery and the robot and MIS surgery? And nobody's doing laparotomies anymore. And the fact of the matter is, while there is some decrease in the amount of incisional hernias, this is data from John Fisher from the National Inpatient Sample, there's still a ton of laparotomies going on. I mean, there really are. And whether it be for trauma or for colon surgery or whatnot, laparotomies are still happening. And one of the interesting things was in the bottom right, not only are we doing laparotomies, but we're doing laparotomies on more obese patients. And as you can imagine, that can lead to incisional hernias. That's probably one of the risk factors. And you can see here in another paper by John Fisher, you can see incisional hernias is a major healthcare issue. We spend a lot of money on it. And there's no doubt that it's an issue. There's been some data from Europe as well. This is really from the French group. They've done a lot of work on cost. And they sort of looked at it the same way Ben Palouse said. If you reduce your incisional hernia rate by 5%, you could save 4 million euros per year. But again, all of these are showing that this is from Dana Tellem. Again, same thing. A lot of patients develop incisional hernias, and it breaks down the years. But I think it's fair to say that we all know that incisional hernias are out there. We fix them a lot, or we try to fix them, and it's a major healthcare burden. All right, let's talk about fixing incisional hernias. I think this is what we all do. We're clearly very invested in this. I think we all think we do a pretty good job at this. And I quote this study, which is probably the most quoted hernia study out there. And really, I use it in a different way when I talk about it, because when most people know of this study, the number one thing they think about is, well, yeah, this is why we use mesh. Mesh decreases the hernia recurrence rate compared to suture. But if you look at it, and this, you can poo-poo a little bit of the data and whatnot, but we don't have a lot of great data about long-term outcomes of mesh repair up to 10 years in a well-controlled study that had good follow-up. And if you look at that, a third of their patients with mesh recurred. Now, a lot more recurred with suture, but that's still 1 out of every 3 patients that we fix, if you believe this data, is going to recur at 10 years. And we sure don't know what's going to happen to them at 20 years and 30 years. And so it kind of thinks that maybe this is, you get the idea that maybe hernia is a chronic disease process, and we're just impacting that a little bit. Some similar data from David Flom in Washington State. He looked at this a little bit differently, but you get this on it, kind of the same idea that at 13 years follow-up, 23% of these patients had had another hernia repair. And so you kind of see that this is a problem, and that we're maybe not that great at fixing incisional hernias. This is the first paper to kind of look at, the recurrent hernias, primary incisional hernias, and then recurrent hernias, and how they're harder to fix every time we do this. What about readmissions? This was a good study recently by John Fisher. Not only are these patients, recurring and we're having to fix them, but he found almost 20% of patients after incisional hernia repair were readmitted within the first year. And the interesting thing, and we all kind of think about this and know this, and thankfully we have the QC, which helps with this, but a quarter of their patients presented to a different hospital. So even if you're pretty good at keeping your own database and trying to follow up patients, 1/4 of these patients are going to some other hospital that unless you really have a adept system, you're going to have a hard time finding those. Of those patients that got readmitted, 35% required a reoperation. 5% were related to bowel obstruction, and then the incisional hernia rate revision was 5%. So these patients are getting readmitted a lot. We're having to reoperate on them a lot. And then Mike Liang did a great study years ago, which again, I think the sort of vicious cycle that we all know is if, after we fix a hernia one time, it's usually a little harder to fix them the second time, third time, fourth time, et cetera. And so I think if we are going to be honest with ourselves, while clearly there's some people that are very good at fixing incisional hernias as a whole and as a nation and as a group of hernia surgeons collectively, maybe we're not so great at this. So how about predicting incisional hernias? And I think this is going to be super important. And I must say, we're still sort of scratching the surface on this. But I think especially if we're going to talk about prophylactic mesh, we're going to need to really figure out who's at risk. And Mike Liang's group has done 2 studies looking at this, probably some good studies here to try to come up with kind of a risk score. They looked at a safety nest hospital in Houston. So it's a little bit, you have to look at this paper a little bit to see kind of, does your patient population match theirs? But basically they came up with in their initial study 4 independent risk factors: laparotomy, hand-assisted surgery, COPD, and BMI, fairly straightforward things that make patients high risk for developing an incisional hernia. And they found that they could really rank patients into class 1, 2, and 3, and really show you who develops a hernia at certain times. They kind of revised this and validated this, and broke patients into low, moderate, and high. And you can see the scores at the bottom here. They added a previous operation to this score based on some data. But basically, you can look at this and sort of calculate people's risk for developing incisional hernia. Now, there's clearly some downsides and some limitations to this study, but it's a nice first attempt to try to figure out who is at risk. And then John Fisher really probably has done some of the best work on this. And he looked at a group from UPenn Hospital. So it's a much bigger sample size. It's a bunch of different operations. And he came up with this chart on the right where you can see all these different risk factors and you can assign a score. And then you can come up with whether they fall into high, low, or moderate risk. So a good way to do this. He also followed this up, looked at more patients, and really put this into a decision-making app that you can get on your phone, and really kind of plug numbers in and come up with a rate of what you think an incisional hernia ballpark may be on these patients. So again, a good first start to sort of help to hone down into who is at risk. And then once you have at-risk patients, you really can give them some numbers based on some data that they fall into. And then you obviously have a shared decision-making with your patients. So I think, again, those are going to be super important. This is the risk calculator that he's come up with that you can put on your phone that I think you may be familiar with. Okay, so just to stop for a minute, I think we kind of said incisional hernia is a problem. I think we all would agree with that. I kind of made the point that maybe we aren't great at fixing incisional hernias. Clearly, that can be debated with this group of surgeons, but in general, we can kind of figure out who is at risk for incisional hernias. And then, so what can we do about it? Well, I think the two big things we can do about it right now are suture and then placing prophylactic mesh. And I think it's, even though this is a talk about prophylactic mesh, it's hard to not talk about suture because this is such an easier thing to do. It's much less controversial thing, although there's some controversy. But if you look at the two big studies on suture, and really we're looking at short stitch suture, the 5 to 8 millimeter bites, you can see that at least in their patient populations in Europe, and we all know that these are not obese patients and they're small patients, but at least in those patient populations, you can decrease the rate of incisional hernias by using the short stitch. Now, having said that, you don't get it to zero. And so even in these hands, 6% in this study, and then the follow-up stitch trial, while it was decreased compared to the large bite, still 13% of these patients, and these are small patients, these aren't obese patients, were getting incisional hernias. So, suturing is good, and I think suturing techniques should be followed, and I think we should learn about them and keep studying them. But we're not going to get that number down by just suturing, especially in some high-risk patients. And so what about prophylactic mesh? And I think most people are aware of prophylactic mesh. Some of the early studies and almost all the studies have come out of Europe, but initially looked at sort of the high-risk patient population. The patients with AAA, and Philip Meissens did a nice study, randomized controlled trial, and showed that he could really almost reduce the hernia rate to zero using a retrorectus large pore mesh compared to primary suture. It added a little bit of time, but really no downsides from there. And this was followed up by the PRIMA study. I think everybody's probably aware of this. This is out of the Netherlands. It's a randomized controlled trial. I think, as people know, the sort of beauty of this trial was not only that they show that the placing a mesh prophylactically can decrease the incisional hernia rate compared to suture, but they showed that an onlay technique was just as effective and has the standard, could become the standard once, in certain patients. And so I think the reason why people that are sort of interested in this is because that technique tends to be a lot easier to do, is something that probably, if non-hernia surgeons may be a little more apt to do. So I think that was an important part of this study. John Fisher and myself did a meta-analysis systematic review. This has been several years ago, but basically what we looked at it, and there's good data. I mean, I think we can talk about this in the discussion, but prophylactic mesh has level 1 evidence in several areas, probably more so than a lot of the other things that we're doing in hernia surgery right now. A lot more evidence, yet it's still controversial, but there's no doubt that placing a mesh at the time of a laparotomy decreases your chance of incisional hernia rate compared to suture. That's been proven over and over again. It really doesn't matter where you put the mesh right now. Onlay, retrorectus, preperitoneal, all of them have a significant decreased chance of incisional hernia compared to suture. And so this data is old, and I can update you a little bit because they're redoing these guidelines. We have some members on the European guidelines where they're redoing this. So we'll have some new information here probably in the next year. But this is 6 years old, and they basically said the data was favorable, but that we needed larger trials, more follow-up before they could recommend prophylactic mesh. And so stay tuned. I think, we'll see some other things. Now, clearly, and Dave's going to talk about this, so I won't belabor the point, and maybe we can have a good discussion at the end. Clearly, everything has a price. And what are the downsides so far of prophylactic mesh? Well, one is seromas. And I think especially for the onlay, if you're going to make a 6 centimeter, 7 centimeter subcutaneous pocket to place your mesh, you're going to get some seromas. And so we need to figure out, how severe those are going to be. Are those a problem or not? And I think it's something clearly to watch out for. Chronic pain is something that it's not super well studied, but I think clearly Mike was talking about shoulder ice repair earlier. There's clearly some issues potentially with mesh, and are we going to see patients that have prophylactic mesh placed to try to decrease their incisional hernia rate, and maybe they don't have a hernia, but they've got chronic debilitating pain, which is pretty hard to treat, at least in the groin, and I assume it probably will be in the abdominal space as well. So something to watch out for. Now, one thing that I'm sure will be discussed is all the mesh litigation, and I'm sure these meshes are getting infected, et cetera, et cetera. Well, the best data we have is from the PRIMA trial, and they relooked at these infectious complications at 2 years. This was the randomized controlled trial about suture and mesh, and basically showed that there was no difference in infectious complications between the suture and the mesh. The mesh was able to be, even in infected cases, the mesh was able to be salvaged in 77% of the cases. The one interesting thing in this case is if you had an onlay and got an infection, a wound infection, then your incisional hernia rate was 30% compared to the patients that did not have an infection. So there may be some downsides to having onlay if you get a wound infection. But at least based on their data in this well-done randomized controlled trial, prophylactic mesh was not associated with increased risk of infectious complications. So and I know there are case reports of this and stuff, but we really just haven't seen that in the data. So I'll conclude here, and I'll try to hopefully convince some of you that this is what my answers would be. Is incisional hernia a problem? Of course it is. We all know that. How are we at fixing hernias? I would say we're not really great at them. If a third of every case we do is going to recur, and then they're harder to fix the more times they recur, I would say that we could sure do better, and we may need to be thinking some other ways to deal with this. Can we predict who develops an incisional hernia? I think we sort of can. We're getting some data on that. Clearly, there's some limitations of that, but I think you'll start to see better and better data on that. And are there interventions to help reduce incisional hernia? I would say yes. The evidence is quite good. It's not perfect. It's continuing to come. And then what are the downsides? I think there are some downsides, and clearly they're going to be downsides as we follow these patients up, and clearly we need to monitor these. So I'll stop there and look forward to the discussion at the end of the presentations. So thanks very much.
Great. Well, thank you. That was awesome. Great overview of the role for prophylactic mesh and small stitch and all the things that we can be doing to help prevent incisional hernias. So we'll turn it over to Jeremy Warren for his talk. May need to unmute, Jeremy.
Sorry, my screen disappeared.
It's the green button that says share screen in the bottom. I learned that.
All right. Sorry about the delay. Lost my screen there. So I'll try to go through this fairly quickly. Some of what I'm going to talk about is overlaps a lot with what Will just talked about. And this topic in particular is kind of born out of our own practice. And we do a lot of ostomy reversals with concurrent hernia repair. These are my disclosures and not related to this talk. So first is hernia after ostomy repair really a problem? Should we do a staged repair or do these concurrently? and then kind of a little bit about technique and mesh selection. I'm not going to belabor that point in this talk. It'll be a little bit more for discussion, I think. So first off, I would argue, yes, stomosite hernias are a problem. The most recent, or a couple of recent reviews have indicated up to 50% of patients who have an ostomy reversed will develop an incisional hernia at that location. Probably higher for colostomy reversal than ileostomy reversal. There's certainly a high incidence of peristomal hernias, and we have a high incidence of patients who get what are supposed to be temporary ostomies who end up not getting them reversed. So I think those three pieces in particular are really important in the conversations that you're having with the patients. When you either see a peristomal hernia patient or you're seeing a patient for potential colostomy or ileostomy reversal. But I think the key, and this has certainly been our approach to this, is an ostomy is a hernia. A hernia is a full thickness defect in the abdominal wall, allows stuff on the inside to protrude through the outside. That's what I tell all my patients. This is a hernia. So it shouldn't be surprising at all that there's a high rate of hernia recurrence after you close this with suture alone, just as Will was talking about. So, the approach to this, I think, is really twofold. And certainly most surgeons, and I tell my patients this, most surgeons would not really consider doing all this at once. It's a contaminated operation. It adds some complexity and duration to the surgery. A lot of people aren't as familiar with that. But you have to consider this as two different operations now. Given a high rate of hernia formation in these patients, you really have to consider that you're probably doing two operations. So look at the morbidity of just ostomy reversals, and it's not low, up to 50% morbidity, up to 5% mortality. SSI rates typically in the 12 to 30% range, and then still have a pretty high hernia rate afterward. And then, of course, with a ventral hernia repair as the second stage operation here, the outcomes can vary widely by technique, and that's a little beyond the scope of the talk. But overall, SSI rates are not as low as we'd like them to be, and certainly still higher recurrence rates than we'd like it to be. So the real concern is, what's the outcome of doing this together, or is there a way that we can combine them into a single operation? And then how are those outcomes? And I think this slide just really shows the concern that most surgeons and even patients would have with doing this as a concurrent repair. You're using a mesh in a contaminated field, risk of mesh infection, that vicious cycle that Will pointed out a minute ago. If that mesh is infected, you have to take it out. And then the risks inherent to an ostomy reversal, like an anastomotic leak, potentially developing a fistula in the presence of a mesh. There is actually a surprising amount of data on this out there. Several studies just published in the last few years. And this was a recent systematic review of 7 studies, 1,700 patients, almost 700 with mesh versus 1,000 without mesh. About 75% of these were ileostomies, less so in the colostomy. But what's really key here is that there were no increased risk in the infectious complications with a concurrent repair with mesh versus suture alone, which I think is really an encouraging thing. And this is backed up in all of these different studies. We looked at our own data published on this a few years ago. This was only patients through about 2015. So we're actually kind of in the process of updating some of the follow-up and trying to get some long-term outcomes on this. But we looked at a total of 359 ostomy reversals. 268 of those were done as a suture repair alone. 91 had a mesh repair. All of these were sublay repairs, 87 in the retromuscular space and 4 in the preperitoneal space. Over half, or about half rather, had a TAR included as part of their operation. And we used the midline or crossed over and reinforced the midline in most cases. And I won't belabor this very long, just focus in here on the SSI rate and wound complications. This was equivalent between the two groups. And I think that's the most important thing. And in particular, the deep surgical site infections, which we considered a mesh infection or a periprosthetic infection, occurred equally in both groups. but we did not have to explant any of those meshes. They were all able to be treated with percutaneous drainage or antibiotic therapy alone. No, we did have a handful of meshes that did require removal, but none were for a mesh-related complication. These are actually patients who had an intra-abdominal complication, 3 anastomotic leaks, a missed enterotomy, and a ureteral injury, all of which required take back to the operating room, and really just not appropriate to spend time reimplanting the mesh when you've had to move it out of the way to get back into the belly. So that is certainly a risk, but less than or about 5% in this study. We did have one patient that developed a stoma site hernia, and that was actually one of those patients who required mesh removal. And then just to bring in some of the QC data, and this is a QC talk, and I think this is really one of the great ways to use this tool, and how we often use it is just we can pull our data, and I just actually pulled this today just to get a snapshot of where we are. We've done 164 ventral hernias at the time of ostomy removal, or reversal rather, since 2013, used mesh in almost all cases, permanent synthetic mesh in the vast majority, 95% of those cases, and almost all were retromuscular repairs. Fairly low rates of readmission, 6.7%. I think that's pretty comparable with most of the published literature on both ostomy reversal and hernia repair. Very similar length of stay to what we've reported previously. Really, at least in our practice now, that's primarily driven by the colorectal side and bowel function. Just a hernia repair, we tend to be a little bit shorter than that with some of our ERAS protocols, and 10.3% risk of an SSI, with the majority of those patients needing some type of intervention. Most of that is just antibiotic therapy. I believe half of these required a percutaneous drain as well. 17% rate of SSO. So I think these are fairly comparable to what we see with a lot of the literature on hernia repair alone. So I think what this shows us is that yes, there is risk of any of these things happening, but the risk is not necessarily any higher when we're doing a concurrent hernia repair. The risk is the risk of the operation, whether it's adding the mesh component to that or not. I don't have data on our recurrence rate right now. We don't have the long-term data in, but stay tuned. Hopefully we will have that fairly soon. So really, just to sum up, there's definitely a high risk of hernia after ostomy reversal. Again, one of the studies that Will quoted from John Fisher's group, the ostomy reversal scored a 3, one of the highest risk categories for risk of developing incisional hernia. And I think it is safe to place mesh at the time of an ostomy reversal. For us, that's a large pore mid-weight polypropylene in the retromuscular space. Again, kind of beyond the scope of this talk, but I think there's pretty good data to say that that's a safe and efficacious place and means of using mesh in a contaminated field. And I do think it decreases our risk of hernia recurrence significantly, though the big caveat there is we do need a lot more long-term follow-up. So I'll stop there and look forward to the questions.
Awesome, Jeremy. Great summary and great use of the QC to continue to follow your data and your patients and use it to make real world changes in your practice. So we'll move over to Dr. Kirpata. Is prophylactic mesh truly benign? And then once he's done, we'll open it up so that everyone can fire questions at our excellent speakers for tonight.
All right, thank you. First off, can you see my screen? Just make sure I did that okay. Okay, good. So I was given the task of answering the question about prophylactic mesh and whether or not it's truly benign. So much like Will, I actually broke this down into some questions. And so my objectives for this talk is really to answer 4 questions. And the first is, number 1, is mesh itself actually benign? Second is, how may prophylactic mesh impact future repairs? Because that's important. And third is, what should plan A be if plan B becomes plan A and plan B requires plan C? And if that doesn't mean anything, hopefully it will at the end. And if prophylactic mesh is not benign, then really how malignant is it? So first, you got to understand what the definition of benign is. And in common terms, it's gentle or kindly. So if you use that in a sentence, you would say Michael Rosen is not benign. Okay, so that's We all understand that. But in medicine, it's not harmful in effect. So basically what we're asking is, does mesh have any harmful effect? Okay. So one thing I think we can all agree on is we have very limited data in hernia surgery on what the long-term complications of mesh are. Probably the best data comes out of Denmark from the Danish Hernia Registry, and this was published in JAMA in 2016, where they essentially looked at 4 years worth of incisional hernia repairs. And fortunately, because of the way their country is set up and the medical system is set up, they were able to obtain 100% follow-up with a mean follow-up of 5 years, looking at incisional hernia repairs. So they looked at over 3,000 patients that had an incisional hernia repair over that 4 years. Just over half of those had a laparoscopic repair with IPOM mesh. And there was just over 1,100 that had an open repair with mesh placed in various positions, either sublay, onlay, and least common of those three was intraperitoneal. And then there is also a smaller subset of patients that did not have mesh. And when you look at their primary outcome, which was mesh-related complications, what's interesting is that they found that the overall rate of mesh-related complications was about 5.2% at 5 years. But if you look at this graph, and probably more interestingly, is that over time, this actually increases. So I think a lot of times we think about placing mesh, and in the first year, if we make it through the first year, it's probably going to be okay. But I think this data would suggest that that doesn't necessarily, it's not necessarily true. And that even out to 5, 6, 7 years, they were still seeing new complications. And these are serious complications, one that required surgical intervention to treat. So that's 5%. So is mesh truly benign or itself? Probably not. Second question is, how may prophylactic mesh impact future repairs? So this was kind of brought up earlier. This was Mike Liang's vicious cycle of complications after hernia repair. And I think when you place a mesh, you have to, it does beg the question about whether or not you are initiating the cycle earlier than what the first repair would be. So are you actually starting a process that you really don't want to start going down? If we look at our own ACH-QC data, and we looked at this a few years ago, trying to look at the rate of inadvertent enterotomies throughout all incisional hernia repairs and ventral hernias, and the rate was about 1.9% in just under 6,000 patients. But what's important is one of the greatest risk factors for development of an inadvertent enterotomy was the presence of prior mesh. Now, when you have an inadvertent enterotomy, it's not inconsequential. You have increased risk of surgical site infections, reoperations, readmissions, enterocutaneous fistulas, and even an increased rate of mortality. So that can be linked also to the placement of mesh. Similar in the NISQIP data by Mary Hahn's group, this published in JACS in 2011, and they looked at 1,400 ventral hernia repairs within the VA system. And one of the things that they found was with previous mesh, there was an increased operative time in those patients when they had a reoperation. And their overall enterotomy rate and unplanned bowel resection rate was almost 10%. So no doubt that there is some change that's going to occur in your operation when there is a piece of mesh already there. Even from Jeremy Warren's group, we saw with laparoscopic ventral hernia repairs that when they looked at patients who had undergone reoperations, there was increased reoperations for recurrence and bowel obstruction, not surprisingly. But their secondary mesh infection rate was 2.4%. Again, mesh infection is not inconsequential, so something that you've got to consider. So how may prophylactic mesh ultimately impact future repairs? Well, does it accelerate the cycle, longer operative times, increased risk of enterotomy, the associated morbidity and mortality? And what about risk of secondary mesh infection? So, all right, what should plan A be if plan B becomes plan A and plan B requires plan C? If that doesn't make any sense to you, then maybe Mike Tyson says it a little better. Everyone has a plan until they get punched in the mouth. So what is this referring to? This actually comes from Dan Smith from his SAGES presidential address in 2010. And I asked him permission to use some of his slides, and he granted it to me, so I appreciate that. But what he was essentially talking about is everyone knows plan A, but it's all about plan B. And what he was referencing was actually the placement of mesh at the hiatus. And at the time, he said, well, what do we know about hiatal hernia repair? And that's that the anatomic failure after primary tissue repair is about 30%. And we know that the use of mesh in repair decreases short-term failure rate to about 10%. So understanding the concept of mesh to repair hernias already well established in abdominal wall hernias. So the most reasonable conclusion is that we should be using mesh to repair hiatal hernias. So that became the new Plan A. However, with Plan A, yes, there was a decrease in hiatal hernia recurrence, but unfortunately, it does not eliminate recurrence. And the pattern of failure of mesh hiatal hernia repair was far worse than non-mesh repairs. And what he's referencing was that there's an increased rate of requiring esophagectomy when somebody has a mesh-based repair and they have a recurrence. And that is a much more significant complication than just a recurrence without mesh itself. So what he concluded is that you really shouldn't be putting mesh unless it's absolutely, absolutely necessary in these cases. So if you take that for prophylactic mesh and you take our current Plan A, which is primary laparotomy closure with suture, and Plan B is the hernia repair with mesh, and we change that to now Plan A as primary laparotomy closure with mesh. Now, what does Plan B look like? Is it a redo repair with mesh? And probably more importantly are there more aggressive and possibly detrimental interventions or outcomes that are going to result from this mesh being in the abdominal wall? So, and last question is, if it's not benign, then how malignant is it? Well, there's no doubt that there is data to support the use of prophylactic mesh. We've seen that already. And if you look at the largest randomized controlled trial, the PRIMA trial, the rate of hernia formation after standard closure was 30%. But with mesh prophylaxis, if you combine the onlay and the sublay, it was 16%. Well, if you do a little statistical math and you look at the number needed to treat, 1 over the absolute risk reduction, that means that you have to treat 7.14 patients in order to reduce 1 hernia formation compared to a standard closure. Well, you can't treat 0.14% of a patient, so you got to treat 8. So what's the bad? Well, if you look at the Danish Hernia Registry and the risk of long-term mesh complications, and we'll say it's 5% based on what their data is. If you look at the number needed to harm, the 1 over the absolute risk increase, 1 over 0.05, that means there's 20. And for every 20 patients that you put prophylactic mesh in, you're going to harm 1 individual. So 20 divided by 8 is 2.5, which means that for every 2.5 hernias that you reduce, you are required to harm 1 individual in the process. Now that math doesn't really add up for me as far as an acceptable risk for prophylactic mesh. And quite frankly, where is the bar for harm? And when you're treating a disease, it's a little bit different because there's already a disease process that needs to be managed. So you're willing to accept a greater degree of risk. But when it's prophylaxis, the bar is raised, okay? Because there are people who are going to get an intervention that ultimately they did not require. So for those people, you really have to consider what the harm is to that individual. So in summary, mesh is not benign. The presence of mesh makes future repairs more challenging. Making Plan B, Plan A may lead to an unknown we really don't want to know. And how much harm is really worth the prophylaxis? So my conclusion would be that prophylactic mesh is not truly benign, but we don't exactly know how malignant it is. So given the potential for harm, prophylactic mesh for laparotomy closure needs critical appraisal with long-term evaluation of the outcomes. Thank you.
All right, excellent. I suggest a virtual fight to the death between Will and David.
I'm ready.
I
can't. I'm not good at math though. So
it's like
Zoom
equations. Zoom Thunderdome. 2 people enter, 1 person leaves.
Yeah, leave me out of this. I'm already broke.
Fair enough.
All right, guys. So we will open this up to questions for everyone. So Ben had a question that William addressed in the chat. Ben sort of said, what do we think of this over the long term? What are we willing to tolerate, Will?
So I think, and I'm going to speak to David's point here, because I think you could do that math, even though we don't, the exact other way, and say, if your incisional hernia rate is 40% and you get a hernia, and then you're one of those 1/3 of patients that's going to recur, and then you're going to get another hernia repair, that's not benign either. So I think, to me, and again, Ben's point, and I think I used to think about this too. What's our rate of mesh infection that we're going to tolerate? I mean, for prophylactics, 100% agree with David. The bar is pretty high. If you have a hernia and you get a mesh infection, you got it. You had a hernia. You didn't cause the hernia, and that's an issue. If you get a mesh infection after a prophylactic mesh, you're going to feel pretty bad. I really do think, and again, I mentioned in my talk, we're just scratching the surface, but I almost think of this like cancer care and chemo. They'll do a genetic test on you right now if you have cancer and see what chemo you're going to get. And I may get a totally different chemo than David based on my, I think that's where these risk stratification numbers are going to really help us. No doubt about it. If I go to you for a colon operation or an abdominal aortic aneurysm that has to be done open, and my risk of incisional hernia is 3% or 5% or 8%, there's no way I'm getting prophylactic mesh. But if I go to you and you can sort of reasonably well tell me that my risk is 48% of getting incisional hernia, I'm going to say, bring on the mesh. I mean, so I really think these predictive models, and they're not perfect, are really going to be important for who we characterize. And going back to your slides on plan A, plan B. Yeah, I mean, of course, I would say probably, and I'm not totally in the hiatal hernia world, but these blanket statements of nobody needs mesh or everybody needs mesh, we just kind of are getting away from that. There are probably a subset of patients with hiatal hernias that need mesh. And can we predict those? I don't think we can yet, but once we can predict who needs it and be very precise about who gets it, then I think our way of our risk strategy decreases. So I don't know if I said that eloquently enough, but hopefully you get the point.
So I think that was very eloquent. I mean, especially when you pointed out that you would get the different chemotherapy than I would, which is typically for the weaker people. But no, I think your point is well taken. I think, if you're looking at it from a genetic perspective and you say that there's a collagen disorder that's going to lead to a higher risk of hernia, I would like to know that information. I think that is important. But I think one of the issues, at least for me, is that a lot of times when you take out these risk calculators and you find out who's the higher risk of getting a hernia, they're also the patient who's the higher risk of getting the wound complication or the long-term, the other complications. So those are typically also the people I'm not that excited about, putting mesh in the first place, or, I just not excited about putting prophylactic mesh at a BMI 45 in the onlay position after a colon resection. It's just, that to me seems a little wild.
But you're happy to put it in on a incisional hernia rate and not think twice about it. Right.
Well, I mean, I'm treating a disease process there. So, I mean, if you give me the rate, you tell me it's 100% at the time that I do the operation, then yeah, I mean, I'll put the piece of mesh in that individual. But if somebody's got a chance of not having a hernia, I mean, I'm gonna put a piece of mesh in somebody that's gonna get infected, and they are not gonna use it.
So I think this is an important question, which we don't have the answer of, and you did a great job, but is prophylactic mesh data going to mirror hernia repair data? And I'm not sure that it does. Hernia repair data kind of poo-poos the onlay, although we've got some reasonable data from the QC, but prophylactic mesh onlay looks great. It's a different potential disease process, as in AK, it's not a disease process yet. And while I think that some of the mesh related complications from that big trial, clearly the longer you have a piece of mesh in, may cause problems, but I think that's where we need to look at some potential for some of the absorbable products or other ways. And so while I think some of the hernia data you can extrapolate to prophylactics, I don't think you can 100% take that as that's exactly what's going to happen in the prophylactic world. I don't know that, but at least earlier.
Can I ask you a question about that? Because this is one of the things I struggle with the entire argument is that the argument for prophylactic mesh is that we're not very good at fixing hernias the way we're fixing hernias right now, which I actually completely agree with. The recurrence rate is way higher than we all want to admit, and this is a very difficult disease. So I agree with that statement, but where I kind of fall off is, so let's treat the disease of hernia prophylactically with the same methods that we're treating hernias. And so aren't we just at the phase where at the beginning of every one of these techniques that we do, we think we figured it out and we got the right mesh, the right technique, the right way to do it, and things look perfect. And then the long-term follow-up for everything is not great. So my fundamental kind of struggle with this is prophylactically treating hernias, I think, has some merit. But if we're just going to do it the same way we treat hernias, and we know that doesn't really work that well, aren't we just putting people who kind of, even at the highest risk group, it's 40%, let's say. That means 60% of people don't need whatever you're giving. So, and that's different than somebody who has a hernia. So what do you think about that?
Yeah, I mean, I agree. I would agree with you to some extent. And sort of the way I think about hernia prevention, and I mean, the talk is always about prophylactic mesh because that's what sort of the controversy is. But I think a whole strategy about hernia prevention is what we need to go to. And it means MIS surgery. It means potentially, and this is debatable, potentially putting your incisions off midline in certain areas. It means suturing better for the patients that, are a little bit high risk. It may mean in some patients, and this is where the all or none comes through. I mean, I don't think prophylactic mesh is going to be put in everybody. I mean, it's going to be a subset of patients that may be high risk, may have some collagen disorder that we don't know about yet, that need it. And so I think when you're talking, and even further, hopefully some better way to close. And there's some, a lot of things out there that are being trialed. I mean, suturing the abdomen, which is what we've done for however many years, like clearly there's got to be some better way to get the fascia back together. And there's got to be some better way than fix a hernia without mesh. I mean, I think you're right. We need to do something different. I think for now, this is sort of because we know hernia, this is sort of the way we're doing it. But I have no doubt that there will be better ways, and hopefully, there will be a subset of patients that need any of all of those.
So, question from Eugene Dickens, and we'll toss this out to David since he is the anti-mesh guy. Does type of mesh influence your willingness to place prophylactic mesh? What about phasics or absorbables? How do you feel about that as prophylaxis?
I mean, short answer is no. It doesn't.
Well, your whole argument was that mesh over time,
Right,
gets worse. So why would it not matter?
Oh,
Sure it's gone?
hold on a second. Let me be a little more clear.
I'm sure it's going at a certain time.
So whether it's absorbing or not, it doesn't matter to me.
I'm not so sure all these things go away like people say they do.
Well, they may not go away at the time frame, but it's going to be gone before 12 years, which is where that Denmark data is.
Well, we're gonna have to wait and see.
Yeah, that's true.
so Jeremy, for your ostomy patients and concomitant ventral hernia repair, what are your cutoffs for comorbidities, right? So do you do this in everyone? Do you have a BMI cutoff? What do you do with smokers, diabetes? What do you do with sort of the usual trio of disaster?
We just operate on them. No, so I do think there's and just to kind of weigh in a little bit on the debate already happening, I think this is a little bit of a different population than strictly mesh prophylaxis. So even though it's sort of called prophylaxis, this is really an incisional hernia repair. So that is a little bit different, and at least in my view. Again, I think an ostomy is a hernia, so you're treating that a little differently. And where some of the best data on prophylaxis comes from is also with peristomal hernia prevention. So placing mesh at the time of an ostomy creation, and then your risk profile shifts a little bit from what Krpata was talking about. Now your peristomal hernia complications can be even higher than incisional hernia, even worse outcomes. So again, I think this kind of shifts you into some of those high risk categories we've talked about. And I think some of Fisher's work and the scoring of high risk is really important. And I think there's a lot of stuff that we just don't know yet. Possibly anatomic considerations, collagen considerations, things that we just simply don't understand about who forms hernias in the first place. Because it's not that every obese patient gets a hernia or gets a hernia recurrence, and it's not that every skinny patient doesn't. We've all had that whole variety of patients, and I don't really know. I don't always know how to predict. You always have to just put in the best risk you can. In our practice, I think we're fairly aggressive with doing a retromuscular repair in most of these patients. And a lot of the data that Dave pointed out of complications with reoperations, most of those are with intraperitoneal mesh. And I do think there's a difference between complications of reoperations with intraperitoneal mesh than extraperitoneal mesh. Data's not great on it, but it certainly anecdotally there's a huge difference. We're trying to look at that now, not finished with that study yet. I'm sure some of you guys have looked at that as well, but not a lot of data out there on that.
Jeremy, the problem with reoperation on prophylactic mesh is nobody gets a hernia, so we don't know what happens when these patients reoperate on
There
it.
you go. There you go.
Yeah. Wait, Jeremy, can I just make one comment about the retromuscular mesh comment? I don't know if Luke Beffa is on this call or not, but he might have a different opinion. I would actually argue that some of the reoperative situations with retromuscular hernia are actually they're different than intraperitoneal mesh, but they're substantially more complicated. And I actually think where there's a little lead time bias in our love of retromuscular mesh, because we're like 5 to 10 years behind seeing what happened with intraperitoneal mesh. And as now everybody gets retromuscular mesh, when those people get big hernias, when those people get the posterior sheath breakdown and you're reoperating on those people, the complexity of that case versus the adhesions, let's say, or, sometimes there's infections or whatnot, the intraperitoneal mesh, I think there's bad in both. And I would say that 10 years from now, we might heavily regret pushing as much retromuscular mesh as we are today. Having said that, I think there's a role for it, like everything. But as it becomes, everybody needs it. There are legitimate problems. And David, I think you would agree, like in our practice, there's no question that probably we see 5-to-1 retromuscular mesh complications over intraperitoneal mesh complications, maybe even greater. I don't know. David, do you agree with that?
Yeah, I think that, and I agree with that. I think you are right that some of those, destabilizing complications from retromuscular attempts can really be detrimental to some of these patients and their function, significantly impacting their function afterwards.
So let me poll the audience while we're speaking of that. And this is my assumption. I don't know if it's true. Let's just say we have some believers in prophylactic mesh. Does the onlay position, I know you're scared about it because of the mesh and the wound infection and getting in, but does the onlay position, probably David, to your point, having to go back potentially, does the onlay position, do y'all think it makes the most sense? Or especially think about who may be doing this? Or do you think, we need to focus on another area?
Well, could you just clarify one thing before everybody votes? Are you talking about peristomas?
I'm talking about incisional.
Well, no, you're saying prophylaxis. So it's kind of, this argument's hard to have because I'm
saying if you have a laparotomy, where does everybody think we should place the mesh? Onlay, sublay, or intraperitoneal?
In a BMI of 40? That's your high risk person.
Yeah.
Well, I think you should put it as an onlay because it's easier to take out if it gets infected.
Well, that's what I'm asking.
It's no big deal to just rip it out.
Or if they recur, it's you just cut through it.
I think people should stay out of the retromuscular space for most hernia repairs anyways, and they should definitely stay out of it for prophylaxis. And I think IPOM is a great operation, but all these cases are contaminated. Most of them are, so it just makes it complicated. So yeah, I think if you want to do it, that's where I'd put it.
My thought on prophylactic mesh in general really has changed over the past several months. The biggest fear I had is really what you said about Kokotovich's data, 5.6% rate of explantation for hernias at 5 years. But you can't just look at that in an isolated way. If you believe that ventral hernia is a chronic disease, and William, you I think said it well. The rates of recurrence are very high, especially as further out you look. You have to consider that in the whole calculus of whether you think prophylactic mesh is reasonable. And actually, I've changed my mind. I actually think it's more reasonable than I thought before I thought about this.
Slowly but surely.
Okay,
I still
Ben.
got some work to do with.
Wait a
mine.
second, Ben. Wait a second, Ben. Like
I knew
to
you were gonna say
answer
something. What's that?
Eugene's question, and I think somebody just said in the that makes a little bit more sense for the general surgeon. So why don't you tell me who's paying for Phasix onlay at Ohio State when like Ohio's going bankrupt? You tell me who's going to pay for every onlay for all your peristomal, all your stoma creations, which is every single patient that gets a laparotomy at Ohio State, high risk patient. Who's paying for that Phasix? Me? Taxpayers?
Yeah, that's a huge problem. I mean,
I mean-
that's something we haven't even figured out for just straightforward hernia repair. But you're right, the hospital eats that cost, and it's a similar situation to bariatric surgery. What they faced about 20 years ago, our bariatric colleagues, no one would pay for it, and so finally, everyone basically came together and said, okay, it is worth paying for bariatric surgery because of the long-term benefits. Whether or not we're going to face that same situation in hernia surgery or prophylactic mesh, I think that's where national organizations got to take the lead.
I do think the question is, and this is debatable, but at least, and I'll just back this up. We have better data on prophylactic mesh than I think you guys have, except for on the use of mesh in hernia repair and laparoscopy decreases wound infection. I don't think there's any better data in hernia repair than prophylactic mesh. The question is going to be, if you can stop a patient from developing an incisional hernia, do you stop that process? And if they never develop incisional hernia, then I think that's a huge win. If you're just delaying something, kind of like David's argument about the hiatus, and then 3 or 4 years later, they get a hernia, maybe that's not the best thing. But if you can stop that process of them developing an incisional hernia, then that's huge.
So to play devil's advocate to that in the final minutes, is that you noted that we have great data that we can prevent that with just smaller bites and smaller suture and no mesh whatsoever.
Yeah.
Right. So do you have any reason that we shouldn't just all immediately be doing that in every single laparotomy? And then who cares about prophylactic?
So this is the great point, right? So there's great data, or pretty good data on it. Nobody does it. They all say their patients are too obese. Mike's patients are too obese. What about the BMI of 40? What I would say is use that. If you're a naysayer, use the short stitch on the patients with BMIs less than 27. Maybe you don't have any, but if you do, use it on those. Don't put prophylactic mesh in. You can get that number down to 5 to 13%. And we don't know about these bigger patients, but that's the idea. Is we think that the patients that are at more risk than the suturing technique still has a pretty high rate of incisional hernia. And so those are the patients you may need to intervene on. And so, I mean, I would say use some of the calculators. You talk with your patient, and, your patient may think a risk of 40 is no big deal. And don't use ever mesh. I don't care if it's 100%. Don't use mesh on me. They may say 40%. That sounds pretty high. Maybe we should try to intervene on that.
So we had one other questions from Eugene Dickens about coding and billing for prophylactic mesh. And well, correct me if I'm wrong. There's a research CPT code to identify patients, but no billable code.
So some places are getting paid for this, from what I hear. I don't know exactly how that works, but if we for sure 100% you need to put in the code, because it's never going to become a code unless we start using it. But I have heard of some centers getting paid for that code. So I think
not for the mesh though, right? Well, you don't
no,
get paid.
not for the mesh. Yeah, sorry, not for the mesh. Nobody, the mesh comes out of your hospital, but if you code it, put the code in, then you may get reimbursed, or if you're in the RVU system.
All right. Well, it's 9:03, so 3 minutes past the hour. I again want to thank our speakers for really just outstanding talks. Great Q&A session. Mike or Ben, when is the next Core Insights?
Yeah, so let me, we'll have it next month, and we'll send out, I can't remember what the topic is next month, to be honest, off the top of my head, but one quick wrap up point about this is that we actually are about to roll out, I think it's about 6 weeks away. We are now going to have questions that are directly related to prophylactic mesh usage. So we'll send a little update to everybody when that actually goes live, but we're in the testing phase right now. So I think, just by the kind of discussion and the interest in this, I feel pretty comfortable. This is, an avenue that we need to provide data and get a more understanding of what is actually happening within our group, and then particularly some long-term information to either address or quell some of the concerns about what's going on. So stay tuned for that. We'll kind of take you through a little map and video of what it looks like to put that information in. It's just a couple extra clicks. So for those of you who are doing it, please be prepared for that, and please put those patients in, because I think it'll be really important for our group to do that. And it looks like Ben just posted it up, but the next core insights will be October 11th, and it's actually going to be a really cool thing. It's going to be about physical therapy and some of the rehab stuff that's going on. One of our committees has been heavily into this and have really put a lot of work into this. So please, we'll send you some information. I think it'll be another great discussion. I just want to thank everybody again. Awesome discussion, controversial topic. And like anything good in surgery, we never get to the answer, so we get to keep talking. All right.
Thanks, everybody.
All right,
Thanks,
guys.
everyone.
Everybody.
Thanks, everybody.
Great.
Take care. Bye-bye.